what I'd like to do is to now get us going in a new way. We mentioned that we needed content. We also wanted different voices and perspectives, and the one that we felt we could not ignore is a parent. But we have kind of a blessing in the sense that we are getting a science writer who has not only parental perspectives, but also real skill in understanding things. The next speaker is Paul Rayburn, who was formerly a senior writer and editor at Business Week, where he covered science and medicine for 7 years. Paul has won many distinguished writing awards, including the Science and Society Award of the National Association of Science Writers, the Associated Press Managing Editors Award for Excellence in Spot News Coverage, and the John P. McGovern Award for Excellence in Medical Communications from the American Medical Writers Association. He's past president of the National Association of Science Writers, and he's written on a variety of topics. So, Business Week, how does that qualify him to come to talk to a group like this? Well, Paul also basically ended up experiencing 9 years ago, he'll probably tell you this, he had a family issue. And that's often why we get interested, and again with the statistics, it's predictable. And he had a son, Alex, and subsequently a daughter, and suddenly he was living this issue and decided, what I need to do is write on this. Now you have this blending of knowledge and stigma reduction. It's personal, it's also simultaneously powerful. And he, along the way, I think did something that we've talked about for this meeting. He sought to educate himself, to learn about it, to talk about the drugs, to essentially acquaint himself with as much information as he could get. He's become a little bit of a science writer expert on adolescent development of the brain and what happens in those very tumultuous years. And his family, I think, has benefited from the learning that he and they have had in the process. Paul wrote Acquainted with the Night, A Parent's Quest to Understand Depression and Bipolar Disorder in His Children. It is that book that's sitting outside for any of you who are interested. And Sarah and I have procured it earlier, and I commend it to you. So with that as an introduction, and with hopefully what will be a very good day, please join me in welcoming Paul Rayburn.
I'm from the media, and I'm here to hype things. I hope things that are important, not things that are unimportant. I want to tell you, basically tell you about my experience with my children and give you some sense of what that was like. I know that many of you have personal experiences yourselves. It's been amazing to me how many people in the fields of psychiatry and psychology have been motivated to get into that work because of personal experiences. So I will talk a little bit about my experience with my family, and then talk a little bit about stigma. But I think in some sense, the whole talk is about stigma, even though I won't use that word, because you'll see that I'm quite angry with what's around to take care of kids like mine, and with what's not around to take care of kids like mine. And I think a big part of the reason for that is because sadly there are still many, many people, I meet them all the time, who don't think of these things as real illnesses somehow. So let me start by describing a scene from some years ago near the beginning of my family's entry into this world. It's early evening, Tuesday, May 7th, 1996. I'm coming home from my job as an editor at Business Week. As I enter the house, I hear my son Alex, who is 11 years old, screaming at his mother. He's being treated with Ritalin by a psychiatrist who diagnosed him with ADHD after a single 15-minute interview. The Ritalin hasn't been working, and so the psychiatrist has increased the dose. But Alex isn't reacting well. He's suddenly much, much worse. I try to talk to him. I try to calm him down, but it doesn't work. He only becomes angrier. He says he's going to grab a knife from the kitchen and kill himself. Where can I hide the kitchen knives, I think? What about my shaver, the scissors, the box cutter, paint scrapers and saws in the basement? Suddenly I'm on a riff about all the things in the house that he might use to harm himself or even harm one of us. So I do the only thing I can think of. I can't make the house safe. I call the psychiatrist. I want to tell him we're in trouble. What should we do? We have an emergency on our hands. A woman answers, "The doctor is not available," she says. "You can call back in the morning." "This is an emergency," I say. "My son is threatening to kill himself. I can't hide the knives. I don't know what to do. You've got to call the psychiatrist. You've got to tell him what's happening here. We don't know where else to turn. We don't know what to do." "Well, perhaps," she says. "I'll see what I can do." We wait. We watch Alex, watch the telephone. We watch the clock. Any of you who've been in a situation with yourselves or with family members who are in crisis, you know what happens to time in those situations. It slows to a crawl. Minutes seem like hours. The psychiatrist has given us a sedative for Alex in case something like this happens. I grab one of the pills, I get a glass of water, I try to hand it to him. He refuses to take it, tries to knock the glass out of my hand. "You're not going to give me any of that stuff," he says. 10 minutes pass, 15, I can't say for sure how many minutes pass, and the phone rings. Amazingly, it's the psychiatrist. So I explain to him what's happening, tell him quickly the story. I'm shaking. I say, "What should we do?" He says, "Call 911. There's nothing I can do for him." "Can you hear him screaming in the background?" I say. "The police won't know what to do. You're the doctor. I need help from you." And I know, though I don't tell him, that if I call the police, they will take him to the local hospital for mentally ill kids, which has just recently been featured in a series in the Bergen Record, the local newspaper in New Jersey, for its gross failures, poor staffing, high suicide rate. That's the last place. I'd rather have him home and cope with the knives and the saws than have him go there. So the psychiatrist won't help. I'm not sure what to do, except that a few weeks earlier I talked to a friend who worked at a hospital in New York, and he'd referred me to a psychiatrist there who couldn't help himself, but said, "Look," he says, "you've got to fight. If you want help for your kids, you've got to fight." So while I was on the phone, I thought, this is the time. This is the time to get angry. So I said, "If anything happens to Alex, I'll make it very clear that I talked to you and you refused to help. I'm noting the time. It's 9:03. And I'm making a record of this conversation. Thank you very much." So he says, "Well, let me see. I'll call you back." So about an hour later, an hour that felt like countless hours, he calls to say that he thinks he can find a hospital bed for Alex in the morning. There's nothing he can do in the meantime. By this time, Alex, who, when I got home, seemed to be possessed with inexhaustible energy, has finally started to tire. He takes the sedative. A few minutes later, he falls asleep. And again, for any of you who have been in this situation, and for those of you who don't, it's quite amazing how serious and life-threatening the situation can be 1 minute, and just a few minutes later, the crisis has passed, and you have a sleeping 11-year-old child in his bed the way he's supposed to be. And there's a tremendous air of unreality about the whole situation. So when Alex fell ill, excuse me for a moment. When Alex fell ill, I entered a part of the national healthcare system in which nearly everything is broken. For the parents of children with mental illness, there's nowhere to turn for help. They can't find emergency psychiatric care, as I found out. Their insurance companies desert them. They can't find a competent child psychiatrist, or they can't afford one if they can find one. And schools deny that they have any responsibility to help. According to the U.S. Surgeon General's 1999 report on mental health, about 1 in 5 children and adolescents have a psychiatric illness. This is familiar to this group. About 5%, maybe a few more, have illnesses so serious that the children suffer extreme functional impairment, as the language goes. There are about 70 million children in the United States. So that 5% with extreme impairment represents 3 to 4 million children. But they are not the only ones who suffer, of course. Add to that figure the millions of parents, brothers and sisters, who also suffer. This is an epidemic illness. and it's one that's hidden and rarely discussed. Sadly, mostly discussed at conferences like this, where most of us know a lot about these things already. Not discussed nearly enough in forums where people still think that people with depression just don't want to do their job. The morning after Alex's crisis, the psychiatrist found Alex abed in a hospital an hour and a half away from our home. The hospital asked for the name of our insurance company so they could arrange to have the admission pre-certified for coverage. The insurance company said it could pre-certify the admission only if the hospital would explain the reason for the hospitalization. Of course, the hospital didn't know anything about Alex. They hadn't seen him, they hadn't talked to him, they hadn't talked to me, they hadn't talked to anybody, but there would be no coverage unless the hospital could make the case for why Alex had to be covered. Otherwise, the insurance company's view was he could be treated as an outpatient. So I made repeated calls to the psychiatrist to try to resolve this, and in the end, we had to have Alex admitted to the hospital with no assurance that there would be coverage. Hospital charge was, I think, in the neighborhood of $1,500 a day. We were going to run out of money real fast if the insurance didn't cover this. But we had to take the risk. What else could we do? As it turned out, a couple of days later, the insurance company did decide to cover things, and that particular crisis was averted for that moment. Now, all of this happened less than 2 weeks after Alex had been discharged from a different psychiatric hospital. He'd spent a week there, been examined by a psychiatrist and a neurologist, given no diagnosis. Nobody could say what was wrong, nor could that hospital refer him to a psychiatrist for us to see. That hospital was about an hour away from the house. He said, well, we don't know anybody in that area. Sorry, good luck. And that's how we got the psychiatrist who made the misdiagnosis of ADHD and prompted the round that I just told you about. Now, Alex was still in crisis several years later. We were still searching for a diagnosis, for some treatment, for some help, when just by chance I discovered that my daughter Alicia, who was 2.5 years younger, had twice tried to commit suicide, once with a handful of Tylenol tablets and once with Advil. I didn't know it at the time, but for weeks at school she'd been in just an intolerable situation. She'd been attacked by the so-called popular girls. This is, in the 6th grade. And the story they were spreading was that she was sexually involved with dozens of boys in the class, or Alicia is a slut. That's the language. That's not unusual in the 6th grade. And what was unusual was that Alicia couldn't cope with it, couldn't handle it. Every day going to school was becoming just an insurmountable trial, and the pills were her solution to that problem, or attempted solution. Now, I have to tell you, if another parent, before I'd had this experience, if another parent said, you know, my child was depressed and tried to commit suicide and I had no idea what was going on, I can tell you what I would have thought. I would have thought, this is a lousy parent. How can this be happening in your house and the parent can have no idea what's going on? Well, I don't know whether that's a lousy parent or not, but that's the parent that I was. I just had no clue. Alicia and I were close. We had, I thought, a great relationship. We used to do a lot of things, just the two of us, and I thought I knew her quite well. She seemed cheery. She seemed happy to me. I just had no idea this was going on. And one of the questions that occurred to me was, you know, I have 3 children. I'm not an expert. I know a little bit more now than I did 20 years ago about raising children. But I didn't know what a teenager looks like. I don't know how that plays out, you know, these young kids who become teenagers and change into these different creatures that you know, we all know about. Yeah, I knew about that. I knew that was going to happen. I knew that they'd be, you know, spreading their wings. I knew all the things that are supposed to happen. But I didn't really know what it was going to look like. So when a 12 or 13-year-old gets quiet and starts spending more time in her room, that seemed to me to be a normal thing. She wants a little more time alone. She's trying to figure things out for herself. She doesn't want to feel so dependent on her parents. Maybe I should have seen that, maybe I shouldn't, I don't know. But my question was, what about her teachers who have seen hundreds and thousands of 12-year-olds? Isn't it possible that they could spot that somebody in class maybe was a little tense or wasn't quite performing up to standards? I know that everybody asks teachers to do all kinds of things besides teach, and teachers rebel at that. But I'm not asking teachers to do something that takes any time. It seems to me that teachers ought to be able to say to parents, your daughter or your son seems a little, uneasy, a little at odds. Maybe you ought to have a talk with them. I don't know whether that would have prevented Alicia's suicide attempts, but why not do that? I think we ought to talk to our teachers and see if we can't establish a little more communication along those lines. Now, I'm going to shift gears a little bit here and talk about my third child, my oldest son, Matthew, who I'm proud to say is a University of Michigan graduate. He doesn't have any psychiatric diagnosis. But actually, I think of him as somebody with a diagnosis that doesn't have a nice name, but what it amounts to is, he's diagnosed with being the brother of 2 kids with bipolar disorder and depression. And this is a much overlooked diagnosis. We don't think too much about siblings in a lot of contexts. And I'm going to, if I can now, quote from a writer who happens to be close to me, my wife, Elizabeth DeVita Rayburn, who has written this book called The Empty Room, which unfortunately is not available out front, but you can find it at bookstores if you're interested in this. And this book is about her experience losing an older brother when she was growing up. Her older brother, Ted, in 1972 was diagnosed with aplastic anemia, which is a life-threatening illness in which the immune system shuts down for no clear reason. Because her father was then a scientist at the National Institute of Health, her brother was put into an isolation room and became one of the 2 kids on whom the movies about Bubble Boys have been made and received quite a bit of press at the time. He wound up living in this sterile room for 8 years, during which time, food was boiled and sterilized to the point of mush for him to eat so that it wouldn't have any bacteria. He had no contact with human skin, anybody else's, during that 8 years, including his family. It was a 10-by-10 space cut off from the rest of the world with a plastic curtain. And so Elizabeth became one of these healthy siblings. Her book is about sibling loss, but a lot of what she says, and she talked to many, many other people who'd lost a brother or sister, a lot of what she says applies to these healthy siblings. So I want to read to you just a little bit from her book to reinforce what I hope you will remember from this when you go back to your homes and to work to think about those healthy siblings a little bit more. So this is from Elizabeth. When my brother died, my world shattered. Not only had the person I loved and trusted most disappeared, but so had the structure of my family, centered as it had been around his illness. We did not know how to rebuild. My parents turned to me to be the central performer, a role I was no longer capable of playing. And no one saw what had happened. My brother's illness, his death, was a profound experience for me. Mostly I was told to be good for my parents. In my home, there was no discussion of my brother. Pictures of him were nowhere to be found. His name did not come up. My parents found it too painful. It was as if he'd never existed. During this time, the only thing that kept me from committing suicide was the fact that I had watched my brother die, seen him fight so hard to live despite the circumstances of his life. When I interviewed 77 other bereft siblings for my book, the thing that shocked me was hearing my experience, my feelings, repeated in the words of others. And yet the sibling experience in situations of sibling illness and loss is all but invisible. It constitutes a black hole in our thinking, culturally and scientifically. I have now been involved with the mental health care establishment for almost a decade, since Alex first got sick. And I'm still not sure, not at all sure, I found too many answers for other families in similar circumstances. I'm a writer and a reporter who has spent most of my career covering science and medicine. I know more about science and medicine than most people who aren't scientists and doctors. And I struggled. I'm still struggling to try to find the right care for my children and to know how to help them. What about parents who don't know where to go for information? What about parents who don't have what I have, which is an opportunity to talk to people like John Graydon and come to conferences like this and go down to the National Institute of Mental Health and more or less talk to anybody I want because I'm a reporter and they'll welcome me in there. And in fact, Alex finally got good care because of professional connections I had, and I got a referral from a past president of the American Psychiatric Association to a friend of his at Columbia. And Alex, after about 4 years of struggling with many, many episodes like the one I related, was more or less cured in about 6 weeks. He was started on a new medication. This psychiatrist, for the first time, monitored the medication. Nobody had done that before, adjusted it, added a few things, subtracted a few things, and it made a huge difference in Alex's life and continues now. He's now 20 years old and in college, and wouldn't be there if he hadn't met this child psychiatrist. Now, I have, as I say, I have many advantages that people don't have. I have information advantages, I have professional access, I have enough money to have paid probably $20,000 or $30,000 for care that wasn't covered by insurance. The psychiatrist that Alex sees, charges $275 an hour, and insurance sometimes pays me $60 and sometimes pays me $40, which even that I can't quite figure out. I've had to struggle tremendously to help my children. So what about all those other people who can't chat with the president of the American Psychiatric Association, who don't have money for care that's not covered insurance? What about the 40 million people who don't have insurance? What are they going to do? The chances that they will find help for their children are practically zero. So I guess to sum up what I've learned from my reporting and my experience on this is that these illnesses are absolutely devastating for families. I had no idea. I will say one thing about, or a couple of brief things about stigma. For the first few times Alex was hospitalized, of course, we told the school people that he had the flu. The last thing I wanted to do was tell anybody that he might have something wrong. I was afraid that parents wouldn't let their children play with him. I didn't know what would happen. But this seemed like one of those private, personal things that you don't share with anybody. It's a family matter. That changed partly because it just became too hard to keep up the artifice, and also as I began to do some reporting on this and think about writing a book, colleagues, other writers, reporters would say, "Gee, what are you working on? What are you doing?" I said, "Well, I'm working on this book. My son has bipolar disorder, and I didn't know what he had then. And my son has something going on, and I'm thinking about doing some reporting on that and writing about it." And rather than, I have to say, in my own circumstances, rather than meeting with revulsion or people who didn't, were somehow put off by this, I can't tell you how many people I'd known for 20 years since I got started as a reporter who said, "My father has bipolar disorder. My child has some serious learning disabilities." All kinds of things that I'd never known about these people, who I knew well. And suddenly when I had a story to tell, they had a story to tell. And I think the lesson for this is that parents need to speak out. Now, we're in a tough spot as parents. Bipolar disorder and depression probably will certainly have genetic components and environmental components. There are things that happen in people's lives that aggravate them. And there are, some array of genes that Alicia has that made her unable to cope with the taunts of the popular girls in the 6th grade. As parents, we are responsible for both the genes and a big chunk of the environment. So if somebody's to blame for these things, parents are doubly to blame for their children's illness. I'm not saying that's the way we ought to think about it. I'm saying that's a way parents might think about it, and I think that's part of the reason that they're reluctant to speak out. I'm angry about this, as you probably have gathered by now, and I get even more angry when I think about I covered a lot of the stories in the early years of the AIDS epidemic, and this was an illness that was marginalized at first, and nobody knew what it was, and it was limited to a small segment of the population that many of us didn't understand very well, and then what happened? An activist group developed. They started chaining themselves to the gates at NIH, blocking traffic, and doing everything they could think of to make noise, cause trouble, get angry, and get help. And I think the results speak for themselves. There's been huge progress. It's still a devastating illness, and there's a lot more to be done. But there was enormous progress in a very short time. If you think about the situation with AIDS in the 1980s, those of you who can remember that, and think about what it is now, it's a huge difference. Think about what happened with AIDS over the past 20 years and what's happened with depression over the past 100 years. We have a few drugs now that we didn't have. A lot of the drugs that we use now were developed in the 50s and 60s. Where's everybody been for the past 40 years? We have SSRIs. I know it's not quite that simple, but from the standpoint of an angry parent, I want to know what the hell's been going on. Where is the research? Where are the answers? Where are the drugs? Where are the treatments that these kids need? And I think part of the reason is because parents haven't spoken out and haven't gotten angry. How many walks have you seen for breast cancer? How many thousands of people? I'm sure it happens here just as it does in Central Park in New York. Gather to press for more attention and more funding and more research on breast cancer. Where do you see the parents of the millions of children with mental illness gathering to demonstrate in the park or chaining themselves to the gates to demand more research? Politics is nice. I love politics. It's great. I love to cover it. We're not going to get help unless we get angry. The normal channels are not good enough. There are families who will go home tonight and watch that minute hand on that clock crawl around the face of that clock tonight with kids in just the situation that Alex was in almost 10 years ago. And reports and pronouncements and nice sayings about how important this is are not going to help that family in that house tonight. So there are a lot of things we can do, and many in this group know much more than I do about this. I think we need to ask the schools to try to do a little bit more to help us recognize these kids. We've got to do something about pediatricians and family doctors who really are the only ones who see most of these kids. And I'd like to do an honest survey sometime of pediatricians and really ask them how much they know about psychiatry. Have they ever really looked at a psychiatry textbook or paper or been to a meeting since they had a 4-week rotation in medical school? And where they get their information, of course. Whatever information they do have, they get from drug company sales reps. Is that where we want our pediatricians to be educated? I don't think so. There are about 7,000 child psychiatrists in this country. So let's say I said 5 million people with mental illness with serious functional impairment. That's make it 7 million, which is within the margin of error. 7 million kids and 7,000 child psychiatrists. Okay, that's 1,000 seriously functionally impaired kids per child psychiatrist. There are 2,000 hours of 40-hour-a-week work weeks. If a child psychiatrist saw 8 patients a day between 9 and 5 every day for 52 weeks, he could have, that would be 2,000 visits. There are 1,000 kids for each child psychiatrist. That would be 2 visits per kid with serious functional impairment. Never mind the kids with important functional impairment, you know, with depression who aren't that serious. Okay. I have to say, I've found in my reporting on this, and as I've educated myself on it, that I find the situation tragic, compelling, and fascinating. There's an enormous amount to learn, and I'm absolutely captivated. I was talking to somebody last night about other children I've met in parent-family child groups at hospitals and in various settings, therapeutic schools, and all kinds of settings. And pardon a lapse into a slight incoherency, but these are cool kids. A lot of these kids, when they're not in crisis, are very interesting kids. I'm fascinated to know more about them. And I continue to report about them and talk to them and write about them. Why can't we recruit more people into child psychiatry? As one child psychiatrist told me, you know, how many other places in medicine can you have this kind of effect on somebody's life? Intervene when a child is 12 or 13 or 14 and give them back, you know, a normal, healthy life, as opposed to something that's either tragically cut short or marred by, you know, continuing, ongoing difficulties and inabilities to function. You know, getting back to politics for a moment, the President has expressed his support for mental health parity. Majorities in both houses of Congress have expressed their support for mental health parity. Let's not let them get away with that. Where the hell is mental health parity? You know, we can't let these people stand up and talk about it. And the reason, of course, is that insurance companies and large employers, like our large employers, wouldn't you think that GM by now would understand that a little health care prevention would save it a little money? When are they going to figure that out? You know, they lost $1 billion in the first quarter, and a lot of it went to health costs. Anyway, if I ran GM, never mind. My kids need help, and so do millions of other kids. I think we've had enough reports and enough study and enough expressions of concern. It's time that we take some action. Thank you. Do we want to do questions, or yeah?
What would you like pediatricians to know, and what would you like them to be looking for in any child, so that you don't have to get to the point where a parent is in crisis?
Well, I think you know, pediatricians ought to be involved in some continuing medical education of some sort. I don't know how it would be set up. That's far beyond my expertise. But you know, the American Academy of Pediatrics is thinking about this a bit. But I think they really ought to urge, I don't know that anybody can require such training, but they really ought to strongly urge pediatricians to get some training, to know how to administer some of these very brief screening tests, and to do that when they have an appointment. Now you know, I don't have the statistics here with me, the average pediatrician visit is, it's either 7 minutes or 11 minutes, but you can do a screening test it doesn't take too long. You know, ask 4 or 5 questions and see if they can spot these kids, number one, and number two, get out and get the kind of training they need to at least, we're not going to be able to take care of all these kids with child psychiatrists and specialists. So they've got to get the training they need to know how to prescribe, to know how to tell the difference between ADHD and a possible possibly manic child, so they don't give Ritalin to the child who might then go into a manic phase the way Alex did, that kind of thing. You know, I don't know how hard it is to teach that, but I can't imagine it's too hard.
Hi, I am a parent and I am angry too. I read your book last night. I'm very new to all of this. I got as far as Alex getting better, and then you started in on Alicia, and frankly, I couldn't take any more. In your book, you said that a lot of what has happened in terms of the clinical aspects of this is more art than science. As a person who spent 25 years in the arts field, I can tell you it looks like bad art. Art is about truth. And what I see here is a bad watercolor where all of the colors get melted together into a big, murky brown work. And I think we have to demand more and better. Listening here about parity, it's clearly an issue, but I heard yesterday, and I hope this is wrong, because it's an outrage, that we have one half-time psychiatrist in the Student Health Center here at University of Michigan.
Have what, 1.5 times?
No, one half
time. I don't,
of a psychiatrist's time in the Student Health Center here, which, if that is true, it means a lot of drugs, psychotropic drugs, are being handed out by people who aren't necessarily knowledgeable about their use and their monitoring. That's an outrage. I mean, we can talk about parity on a national level, but why aren't we pounding on the desk of Mary Sue Coleman and asking for a lot better than that? And I would guess on a lot of campuses it's very much the same. So that's one point. The other point is that we had a major representative of our federal government here yesterday when asked a question about, once we get past the stigma and we get all of these people coming in and asking to be diagnosed and asking for services, where is the availability of care for these people? Your point about child psychiatrists is also true in the adult psychiatric community. There's no way, and his answer was a sort of free enterprise, free market system. Well, the supply will appear when there's the demand. Well, these are not cars and widgets. We can't tool up to meet these people's needs in such a short time frame. And also, I think there's a parent stigma, too, that you didn't really talk about. I think everybody thinks kids don't want to talk to their parents, that somehow parents shouldn't be in the picture, or if they are, they're grossly incompetent and uncaring and dysfunctional. That may be true for some, and maybe all of us, but we all want to be there, I think. We all need to be there. And finally, I think the science, I mean, if there is art involved, why can't we have, instead of a murky watercolor, a Vermeer or a Michelangelo, shoot for the top? We deserve better than this. That's
I couldn't agree more. I couldn't agree more. Thanks very much for saying that.
I'm going to jump in just very briefly because I couldn't also agree more, and yet one of the things that I think in this audience especially we all have to address is that something that people have been working on for 20, 30, 40 years isn't going to be changed by snapping fingers. We've had a shortage of child psychiatrists forever, and all kinds of people are attempting to try and remedy this. I currently have the distinction, honor, and burden, I think, of chairing the latest NIMH task force called the National Psychiatry Training Council to try to address this. Michelle Reba, who is sitting over there and will chair the next session, is the current APA president. We have a problem, and this is not going to be solved, and I would like to think differently, because I believe that as a psychiatrist we really do carry around a lot of expertise, but we're not going to solve it by just waiting for more psychiatrists. It's why I mentioned this morning, that yesterday's session that I heard from Karen Swartz, we've got to work hard at training the pediatricians, family physicians, obstetricians, nurses, etc., in a better way, because frankly, right now they are the front line, and we've got to do this in a collaborative way. So let's not wait just for psychiatrists. Let's do this in an entire team fashion. In the meantime, I'm not going to stop my efforts to try to improve the numbers and the quality of the psychiatrists. And I just motioned to Dr. Bonnie Fahman, who is standing here. She happens to be one of those few short supply people at the University of Michigan. And Bonnie?
I'm actually the half-time psychiatrist that works at Student Health. And I wanted to clarify a little bit what our mental health system is on this campus. Certainly the reason we've been able to do this conference is I think we have pretty good coverage and we are working towards improving it. But in addition to me at the counseling service, there is a full-time equivalent physician and nurse practitioner who do prescribing. The strongest, there are two things. One is that we have a wonderful primary care physician staff at Student Health who are really, yes, they're the front line, but they are generalists. They are familiar with the stresses that adolescents in college go through. Most of them aren't physically sick. This is not a campus where we have a lot of chronic obstructive pulmonary disease and a lot of heart disease. These kids come in with stresses, and the primary care physicians as the front line know what they're doing, and if they have any question about it, they call me. And so I serve as a consultant. I'm not just the psychiatrist that sees all the students, but I'm the consultant to a dozen or so primary care physicians. Not sure what more to say than that. I guess the other emphasis needs to be that medication is not the sole treatment. So all of the counselors at the Counseling and Psychological Services Center, all of the therapists at the psychological clinic, and numerous residents in our program take care of students. There's a pretty broad coverage.
My only comment on that would be that just to say again that of course we're at a distinguished elite institution here, and we would expect things to be better here, and we always, I think, have to remind ourselves about everybody else out there who doesn't have the advantages of being a student at the University of Michigan.
I want to segue also into Dr. Kurz is one of the primary care physicians who works at Student Health and whom I consult from time to time.
And in addition to the person over at CAPS and Dr. Feldman, we have recognized the increased need for psychiatric services on campus, and our director is in the process of trying to, we've got some extra space that has freed up in the last year or so, and in terms of looking at how to use that space, we've decided that that space will be used to build some additional psychiatric services. So we very much recognize the need. And there are some of the primary care physicians, myself being one of them, who has a very, very strong interest in mental health needs of students and has worked very hard to educate myself on the treatment of the disorders and feel very comfortable using the medication. So we're probably doing a little bit better job than was initially thought.
Can I give a dose of reality? I'm a parent of a child who's had depression at University of Michigan, who was turned away by the health department here, by the primary care physicians here. She was a member of an athletic team here, was turned away by her trainer, was not recognized by her pediatrician, went to CAPS several times. Friends went to CAPS, pounded on their door, said, please take care of this girl, was referred out through CAPS, and once you are referred out through CAPS, you cannot return. The counseling, she was told, was available for parents or children who were having difficulty with breaking up and separation from home, but they were not equipped or able or willing to treat anyone. And actually, I think this is appropriate with true mental illness. So I love the University of Michigan. They have been wonderful with my daughter. The administration has been spectacular. Her professors have been supportive, and her RA and her housing community has been spectacular. And I would recommend, I really do believe that that coming to university was part of her destiny. But I also believe that CAPS and every psychological department needs to open their ears to hear that, yes, we understand you're working and you're trying, but when someone has a complaint, you need to hear and you need to listen to your students.
On that, I've spent the last 30, 35, 40 years in operating rooms and hospitals, and the real front line is the nurses. If we can train the nurses to be alert to this, because the nurses spend more time with the patients than do the doctors. That's a fact. But anyway, my question, my point that I wanted to talk about was, you brought up the healthy siblings of sick kids. Is there support groups for that? Is there venues for them to vent their problems?
There really isn't much that I know about. There may be a few things in the cancer field, but there's very little. And this is an area that's ripe for patient and family activism and initiative to try to form some groups. There's very little concern. There's very little research on sibling loss. It's just not an issue that people think about. When a child is sick, everybody's thought, including mine, everybody's thought is how horrible that is for the parents, or when a child dies. And we need to start thinking about the brothers and the sisters who have long lives ahead of them to try to grapple with these experiences they've had when they're younger. So there really isn't very much, I'm sorry to say.
Thank you.
Mm-hmm.
Well, that was kind of a segue, although I don't think it was planned, but actually I facilitate a large support group with over 100 members, and about 20% of the people are support people, both parents and siblings and significant others. And the thing, it's a Depression and Bipolar Support Alliance, and there's over 1,000 chapters in America. But one thing I would say is a lot of times health professionals don't know about it. It's amazing to me how many health professionals do not know about DBSA, and they're very receptive whenever I take brochures to their offices, but I think somehow, some way, maybe even DBSA Chicago could make a push for more publicity, because again, we have 40 people every week and 100+ members, and it's very important to them. I mean, these people are either people that are getting well if they have the illness, or they're able to support people. And sometimes the support people came first to the meeting before the patient or the client did. Mm-hmm. So that's one thing, and maybe if you have ideas about what we as a support group could do to promote, since you're a writer especially, if you have any way that we could contact you later with you have a laundry list of suggestions, we can distribute that. And I mean, we have a huge voice in the community. Mm-hmm. We could really help, I think.
Well, I'd be happy to chat with you afterwards, or if for some reason we miss Sarah Newland or Dr. Graydon or somebody can put you in touch with me, and I'd be happy to chat about that. And I'll certainly mention DBSA in the future as a place to go and look for some help.
Yes, there is. It's dbsalliance.org. It's a good organization.
That's dbsalliance, all one word, .org.
Hi, I'm a college senior at Emory University.
I'm sorry?
A college senior at Emory University, and I just spent the last year engaging in a very intense mental health anti-stigma campaign at my school. And what happened was I got sick there and had a negative experience with the counseling center, and I got very angry. I mean, extremely angry. So what I did was I started, asking a bunch of questions, and ultimately developed a really good rapport with the counseling center there. And what I discovered was there is a crisis on college campuses in terms of the volume of people such as myself who need these services. And counseling centers are overwhelmed. I mean, absolutely overwhelmed. It has become a resource issue. And because of that, there exists a debate between universities and I think parents as to whose burden is it to supply, resources and support to students. That's something that has to be acknowledged, because right now I don't believe that university resources have the capability, the capacity, or the resources to, take care of students such as myself. So I understand the significance of anger in terms of politics. I believe me, I do, and I do think that we should be angry at the system as a whole. But the question becomes, where should we place our anger? I don't think it does any good to turn to counseling centers or resources at schools that feel, and these are good people who truly, try really hard to do the best to treat as many students such as myself as possible, but they're tired, and that's the reality. They're exhausted. So the question becomes, should we use our anger to turn towards the universities, or should we go beyond that? Should we look towards the state legislatures on parity issues? Should we look towards Congress on parity issues? You know, I think that it's extremely important to identify the problem.
Yeah, I mean, my answer to that would be all of the above. You know, I know that anger is not always the best way to change things in the public sphere, but it's one way, and sometimes it helps. I mean, we know that it sometimes helps get change faster.
Granted.
And it's missing from this arena.
But I really was uncomfortable when you blamed the parents and said that parents have to assume a responsibility, because I can tell you right now, my parents suffer from depression, you know, and granted, you know, there's environmental factors and whatnot, but parents are equally exhausted, you know, and so I don't know if there's necessarily anyone to blame or to assess blame. You know, the fact is that there's a reality.
What I meant to say in sort of, it was sort of blaming the parents in quotes. What I meant to say was that many parents feel that way. They feel they're responsible. Okay. Many others feel the parents are responsible. That's a thing. That is, I think, one reason why there aren't more parents speaking out, because we perceive that, you know, I mean, I have 2 kids out of 3 with mental illness. What must be going on in my house? That's the thing we need to fight against.
Okay. Thank you.
Hi, my name is Ken Werner from Kalamazoo Community Mental Health Services. I guess I'd just like to respond in terms of the staffing of university psychiatrists. There is a lot of historical information on college psychiatry, and I don't know if the American Psychiatric Association has identified college psychiatry as a specialty in and of itself, although it ought to be considered that way, because the medications that are often prescribed to college students need to take into consideration keeping them functional, keeping them able to learn. So obviously the medications you give to someone for depression at the age of 60 is not going to be the exact medications you're going to give to an 18 to 23-year-old who has to learn and perform well in the classroom and on exams. And there is quite a bit of historical information on the father of college psychiatry at Yale University back in the 1920s. So if it's not a recognized area by the American Psychiatric Association, it should be. The other thing is, I've interviewed many faculty members at Western Michigan University who have said to me they really are looking for full-time psychiatrists who can perform a community psychiatry function, get out there, educate faculty, be part of the campus community, and not just sit in the offices and write prescriptions. And at Western, we've had a turnover of half-time psychiatrists of about 4 in the last 4 or 5 years. So I think the caseloads have quadrupled, and there is definitely a need to consider a full-time university psychiatrist who practices from a community psychiatry model.
Child psychiatry is a board-certified specialty, is it not? Yeah, it is. I'm not sure this is working. Is it?
You're going to focus your anger. I'm not so sure that that false comment really gets registered. $1,700 to $1,900 of every vehicle right now in America is being spent on healthcare costs, and much of it is being badly spent. And mental health is almost always second on the list. What are they doing about it? You know, and I think at some point in time the anger really ought to be the decision making and the money. And I hate to jump in on this, but I feel sometimes we've lost the parity fight. We've got to keep going and get it done. But getting parity and inadequate payments isn't going to solve all of this. We need 4 times more money. You know, and I think it would be a good investment for society Paul has done something today that I really like in this because he introduced the element of anger. And I think what it is I would put a different framework on it just simply because that's my character. I would say we all need to be activists. If you go home and you sit on your hands, we're missing his point. And I think we're not going to make a difference. There are two people here that still would like to say something, but we are now 8 to 10 minutes into your break. I suggest that we take that break, that you find Paul. You get a first crack.
Well, actually, my comments were for the whole auditorium.
We'll do the last one. And then what I want to point out is the panel is in here. Dr. Rico will be introducing that, and she'll introduce the panelists. So we'll still try to stay with us well for 15-minute break. Try and expedite it a little bit. Come on back in because we want to get back on stage. And that's also a group that is trying to move this forward. So make it come. Go ahead.
Thank you. I'm Georgine Thompson, licensed clinical social worker, Oregon State University. And I wanted to comment about the services on campuses. We also have a part-time psychiatrist, but we also have a very good health center staff with physicians who are very capable of and understand depression. Some of the data they collected showed that we treat more students with depression than we do students with a common cold. So they're very much into it, and we have nurse practitioners. My concern is, and where the activism comes in Oregon, Senate Bill 510 would keep our general practitioners and physicians in the student health center from prescribing antidepressants. Only psychiatrists. Now, I think in the wisdom of our legislature, I think Oregon is a progressive state. This bill may not go through, but just to let you know, there are people out there, and I think the person who drafted this bill with a legislator was concerned about the amount of Ritalin that's being prescribed to children and teachers making referrals for medication, I'm not sure. I've never talked to the man that drafted this bill, so I shouldn't say specifically what his concerns and motivations were. But he was concerned enough to draft this bill. And here we're talking about depression as an illness, and so your general practitioner ought to be able to prescribe antidepressants. So just be aware of what the mental health legislation is in your state and keep track of it so that you can let your representatives know your feelings and thoughts and the actual data that we have to influence their votes.
Thanks.